Look at that.
Yeah.
All right. So good evening, everybody.
Just go with you. No.
Please remember to mute your microphones if you don't mind. So good evening, everybody. Welcome to Hand in Focus, Scaphoid Nonunion. Thank you for joining us tonight.
Shoot, I can't turn the volume up.
My name is Harvey Chim. I'm from the University of Florida. And together with Carl Eblin from MGH Harvard Medical School, we'll be moderating this session. So today, we're very privileged to have two great papers for discussion. The first is entitled, Does Proximal Hamate Graft for Proximal Scaphoid Reconstruction Restore Native Wrist Kinematics? And we have Dr. Bassem Elhassan, who will be joining us tonight. And our second paper tonight is Clinical and Patient-Reported Outcomes of the Hybrid Russe Procedure for Scaphoid Nonunion. And we're privileged to have Dr. Kamal from Stanford join us tonight. And next, our expert for tonight is Dr. Jim Higgins. He's the Chief of Hand Surgery and the Hand Fellowship Program Director at the Curtis National Hand Center in Baltimore. And Dr. Higgins is really an acknowledged national and international expert on scaphoid nonunion. So again, we're really privileged to have him tonight and really look forward to an exciting discussion. So this is the format we'll be following for tonight. For each of the papers, we'll start off with an author presentation to just give us a brief synopsis of the paper. Subsequently, we have two residents, Nick Kaloda and Chao Long from Johns Hopkins, who will each be discussing the articles and how it will affect their new practice. And this will be followed by expert discussion by our expert, Dr. Higgins. And finally, we're going to have an open Q&A. So again, please mute your microphones and please turn your camera off while the speakers are presenting. Cameras can be turned on for the Q&A session. Please ensure that your Zoom screen name is your first and the last name, and please really ask questions. Please ask questions through the chat, and we'll try our best to answer all your questions. This will be an exciting discussion. I really look forward to it. And again, this session is designed to be engaging and interactive. So without further ado, I'd like to invite Dr. Elhassan to start us off with his paper.
Great, thank you. Thank you very much for having me. Can you allow me to share my screen, please? I cannot.
Yeah.
Okay, great.
Of course.
So customize. There you go. Okay, so does proximal hamate graft for proximal scaphoid reconstruction restore native wrist kinematic? I have to give a lot of credit, in fact, most of the credit to Sanjeev, Kakar, my partner from Mayo, and the rest of the author, Marion, as well, Joe Gill and Alex Hooke, who really worked hard on this paper. So what are options for like 18 years old male, left scaphoid nonunion, RIF 12 months ago, failed, bone stimulator tender to palpation, and you have fragmentation of the proximal pole of the scaphoid with the screw. And the most common is like Jim Higgins is going to talk about it right now, which is MF, the medial femoral condyle or rib graft. This one, in my opinion, is non-reconstructible otherwise. And we described the proximal scaphoid, the proximal hamate reconstruction for the scaphoid. And if you look at this 3D print of the wrist for scaphoid nonunion, look at the hamate, look at the scaphoid, and look at the shape. They're very, very similar. This is how like we came up with this idea a while ago. And you can look at the shape. So if you look at the reconstruction, and I'm glad Rob did one today because it's really very simple. What's interesting, if you look at the proximal hamate and you look at the articulation, it's almost like the articulation of the medial scaphoid. So if you resect up to half of it, the volar aspect have even ligamentous tissues from it. So you can take it and flip it. You can use this ligament for dorsal ligamentous reconstruction, and you key it in at the level of the scaphoid deficiency, and you fix it, and you can pin temporary if you want the null capitate, and you can have this kind of outcome with this kind of scaphoid reconstruction. And I borrowed these pictures, Rob, this for you from today. In fact, Rob, he did this case today, and you can see this is P and this is after. It looks pretty sexy, by the way. Good job. So very quickly, topographically, how did they look like when we studied it? This is, again, I give all the credit to Sanjeev Kakar when they tried to do the surface correspondence between the hamate and the proximal hamate and the scaphoid. And what they found is like the mean surface to surface area was below 1 millimeter. They're very, very, very close and very, sorry, very similar. And then when they talk about the biomechanics from the transfer, like when we do, for example, when we try to do proximal hamate resection for arthrosis, sometimes you can resect a big portion of it and no change in the biomechanics. By the way, there's a loud voice in the background. But what they noticed also with the osteotomy, the mid-carpal kinematics was maintained, and there was no significant difference in the lunocapitate kinematics between intact and post-hamate osteotomy, which is what was very interesting. And then they tried the same, like also with the help of Sanj, to do the biomechanical difference in the wrist between rib graft, medial femoral condyle, and hamate. And very interestingly, all three grafts performed relatively the same, and none of them resulted in notably drastic kinematical change, which is very interesting. And now we'll talk about does proximal hamate graft for proximal scaphoid reconstruction restore wrist kinematics in 8 cadavers. We did use the motion trackers to apply across the radiocarpal and midcarpal joints along the scaphoid, capitate, lunate, and radius. And we loaded the FCU, FCR, ECRL, ECRB, and ECU with this specific simulators. And essentially, the wrist was moved in flexion extension at 40 degrees and radial ulnar deviation 30 degrees and 100 cycles. And the cadaver testing was intact state, scaphoid fracture, hamate to scaphoid transfer. And this is set up at that time. And this is a finding. What's noticeable is hamate to scaphoid reconstruction significantly corrected the abnormal motion of the scaphoid relative to the lunate in the coronal plane. Also, during radial ulnar deviation, the hamate reconstruction corrected the abnormal scaphoid kinematics to the lunate in the sagittal plane. So it really if you look at the lines, the intact is the blue, the green is the graft, and the red is the fracture. You can see the restoration essentially of the kinematics. So in summary, many treatments are available, but hamate is a local bone grafting. It addresses scapholunate instability, and topographic, biomechanical, and kinematic studies are encouraging. But of course, we need larger series with long-term follow-up. Thank you very much for having me. This is one of my latest pictures from the Mayo Clinic with their group at that time. Thank you.
Thank you, Bassem. That was great, and I love that picture. Next, I'd like to invite Nick Kaloda to give us his comments on how this paper will affect your practice.
Awesome. Thanks, Dr. Chim, and thanks, Dr. Elhassan, for giving such a wonderful overview of that paper. Obviously, this is a humongous topic, and I'll try to keep this to 2 minutes. The thing that struck me most about this in plastic surgery, and certainly as a resident, it's hammered into us time and time again that the principle of replacing like with like is typically considered the gold standard in whatever reconstruction you're trying to achieve in the body. In the case of these proximal pole scaphoid nonunions, as Dr. Elhassan mentioned, we have options, such as the MFT flap from the knee or, rib cartilage from the chest wall. But those are technically challenging operations. We're lucky enough to spend time with Dr. Higgins and learn about, the MFT operations, see that. There's a lot that goes into that, a lot of preoperative planning. There's the technical skill, and then there's the downsides of introducing the morbidity of a truly distant surgical site. So, for me as a hopefully starting hand practice in the next few years, there's a lot that's intimidating about that. So
Nick, you're on mute. Could you unmute yourself?
Sorry about that.
Thanks.
There's something definitely appealing about the truly local donor site of the hamate graft that can be used here, and especially that it comes with this ligamentous attachment that can be used to reconstruct the scapholunate ligament at the same time, which they spend a lot of time talking about in the paper. So kind of the two big questions I have that Dr. Higgins, hopefully you can shed some light on is, one, what effect do you think is the recapitulation of normal wrist kinematics is from the hamate graft itself reforming the proximal scaphoid versus reconstruction of the SL ligament? And second, this paper looks at, flexing these cadaver wrists about 100 times, I think was the number they did. We know a lot of the complications from this in the form of slack and snack wrist occur over many years. What do we think is the translatability of this data over just 100 cycles of the wrist to something that might take years to develop? So those are my main things that I wanted to think about if I was going to translate this to my practice. So Dr. Higgins, maybe you have some comments on that.
All right. Thank you, Nick. That was great. Next, I'd like to invite Dr. Higgins, our expert, to deliver his slides. And please go ahead, Jim.
Well, Harvey, I'd love you to stop using that word expert because you're putting a lot of pressure on me here. But First of all, huge applause for this contribution, I think, from Sanj and Bassem, because it's tremendous work. It's something that's really great to have stumbled upon to a degree, to say, this looks a lot like the proximal scaphoid, we should use it, and boy, it's in the same field. But it brings into question this issue of the non-reconstructible proximal pole. And in my mind, when somebody says something is non-reconstructible, I always hammer into the fellows, for me, non-salvageable, you know, that's sort of an opinion issue. But for me, it's any primary surgery where the proximal piece is less than 2 millimeters on the sagittal coronal or sagittal cuts on the CT scan, or secondary surgery where the piece is highly comminuted, usually from Hooke stress damage from the previous screw, or any tertiary surgery. So in those categories of patients, that's when you're thinking about this operation that Bassem is describing. For me, as you've heard, we do a fair amount of osteochondral reconstruction using the knee, and we have developed over time our cutoffs for what is and what is not inclusion criteria for these patients. And as it turns out, we keep these in patients that are under 40 years of age and under a BMI of 35 from the standpoint of the difficulty with recovery from the knee. So for me, in my practice, I've been looking with great interest at Bassem and Sanj's work about how is this going to turn out, because right now, those are the over 40 or the BMIs greater than 34s where I've entertained this or the osteochondral reconstruction in a non-ablative option. So I will say that we've studied this in the lab in a pig model to try to determine if there's a difference in having the vascular pedicle and not having the vascular pedicle. So this was a study we did, a sort of multinational surgical study that was done in Turkey, where we did osteochondral flaps and grafts elevated on the medial femoral condyle of the pig. And this is because the pig actually has very similar descending geniculate artery system. We harvested a graft and we harvested a flap immediately adjacent to one another. We put them back into their native position after laying a thin layer of methyl methacrylate cement so as to prohibit ingrowth from the underlying bone. And this way, when the pigs were allowed to recover, this is the recovery room here, survive, run around, eat, ambulate, and cycle their knees for 6 months, and then they were taken back and we harvested these grafts versus flaps, we showed that there was a tremendous histologic difference between the grafts and the flap. And as you would anticipate, what we did was we had a blinded musculoskeletal pathologist use the International Cartilage Repair Society Visual Histologic Assessment Scale, of course, what you would all use, only to find out that the grafts perform better histologically, but that may be irrelevant. So in my mind, I think there's some value to the microsurgical anastomosis, but the hemi-hamate or hamate graft and the costochondral graft have significant advantages, and the histologic difference may be irrelevant clinically. When I look at these two, I would say to myself, there are some significant differences. The costochondral graft certainly has a large published experience, so I can sort of lay my reliance on that. It's easy to carve into shape, it's easy to overstuff, and it has a very thick piece of cartilage, but there's a huge inframammary scar that is required to harvest this thing. Whereas with the hamate, it's the same site surgery. And I've been sort of waiting for Bassem to show us the longer term and larger clinical series outcome. And I do worry a little bit when I'm doing an MFT, for example, that I'm really traumatizing the radiocarpal joint. It's a massively invasive procedure, but we leave the midcarpal joint pristine. We purposely do not open it, because there may be a need for a salvage maneuver in the future, and that would be a PRC. So I wonder about the effects of doing big surgery in the midcarpal joint and doing big surgery in the radiocarpal joint. So for me, those are sort of the questions I wonder about. This is a patient that I just saw back in the office 2 days ago who came in at age 20, who was definitely at an elevated BMI. And this is a costochondral rib graft that I'd performed 15 months ago. And he's had an unbelievably good outcome, but this may very well have been obtainable with the hamate as well. So I would say, for me, the questions aren't what's going to happen with an instability pattern from the harvest site. That's been shown very nicely by Sanj and Bassem in 2020, and also by the Sandy Palmer article in 2004. This is trying to answer, what will the resection of the proximal scaphoid and the replacement do with an instability pattern? Now, we did this for MFTs in the lab, and we tried to create an instability pattern for this to answer this very question. And what we did is we tested the intact specimen, sounds very similar to this study. We resected the proximal pole and tested it to see if the patient went into DZ. We then replaced it and checked if we, just by putting the proximal pole back, could fix the DZ. And then we overstuffed them. And this concept of overstuffing we've talked about in the past. Overstuffing was created by inserting a methylmethacrylate spacer in the mid-body of the scaphoid. But what we found, and this is, I guess, my point, the hardest part of these studies is to actually create the DZ. So when we had the intact specimen and then we simply resected the proximal pole, it would not go into DZ unless we took down all the secondary stabilizers. And this speaks to Nick's point. We had to take down the STT ligaments and the dorsal ligament in order to get a 12-degree difference in the radiolunate angle. And I noticed, Bassem, and this, I guess I'm getting to the point, is what you labeled as instability after creating a fraction of the proximal scaphoid. The differences there, what was statistically significant, was actually 3 degrees, 2 or 3 degrees on a radiolunate or scapholunate angle. And the question is that really, like if you saw an X-ray and it changed 2 degrees or 3 degrees, would that be clinically relevant? I think it's very difficult for us to say what is and what is not an instability pattern, and whether or not putting the Hamate in there or the MFT in there, frankly, is actually fixing the instability pattern if the instability pattern is only 2 or 3 degrees. This particular study was not, can we put the MFT back in there and recreate the same size of the scaphoid? We wanted to overstuff it. So I know I'm going above and beyond the realm of discussion of this paper, but I think what we're seeing in this discussion of this paper was an instability pattern defined as a 2 to 3 degree difference in the radiolunate angle. Maybe you could speak to that, Bassem. You're muted right now.
So, Jim, like you're talking about the overstuffing and how it affects the stability of the wrist. This is a question.
Well, I just wondered, when you were doing the study and you created the fraction of the proximal scaphoid, the instability pattern that was labeled was noted with a flexion extension arc of the wrist created a difference of 2 to 3 degrees of the scapholunate angle.
That's true.
So I guess what I'm wondering is that clinically translatable? Meaning, does it show when you go from neutral to -3 degrees and then back to neutral, does that really demonstrate to us that reconstruction of the proximal scaphoid is fixing an instability pattern?
Well, that's an excellent point. I don't, like, if we want to talk realistically, if we want to translate this one into a real clinical setting, I am not very sure it will be. But like most of the anatomic study that we do, sometimes we cannot translate it fully into clinical. The problem is, and it was mentioned before, like about the chronicity of it, and when we have an established problem from this deficiency of the proximal scaphoid. But the point, to be honest with you, even the study that you showed, if you want to think about it, is reconstruction of the shape of the scape. If you reconstruction of the shape of the scaphoid, whether you overstuff it or not, and you try to repair some of the ligament, I think it can get you as close as possible to the kinematics, but I do not think it restored fully the kinematics. No, I agree with you.
Yeah, I think the study was fantastic, and for me, when I look at this and I say, let me skip the slide here. You know, what are my questions for the future of the Hamate graft? I know, and it's been shown very nicely by your team, that actually resecting the proximal Hamate is not going to change kinematics. And I think what was attempted to be shown here today is that if you replace the fractured proximal scaphoid with a like-sized piece of bone, you can restore kinematics. But I think ultimately it's going to be.
So Jim, like, to be honest with you, for me, like the idea, like when I came up with this idea a long time ago, it was because sometimes when you have a Holt lesion, you go in arthroscopically, and you have studies about it. You have long-term outcome about resection arthroscopic of the proximal hamate, and you don't without ill consequences. I said, you know what? When we went and I look at this, like, okay, since we resected sometime for a little bit of arthritis, and sometimes you take a good portion of it, nothing happened. Why can't we use it for the same reason? This is how, honestly, it came up for me originally, and this is how everything came up after that. So when we talk about the whole thing, we go in arthroscopically resect the hamate for pain, for specifically these lesions, and no changes. Well, even clinical, the changes are very minimal. This, I thought it will not affect as much the kinematic, but so you're still touching the mid-carpal joint. What's going to happen over the long term? The longest follow-up now is close 8 to 9 years right now. And the last point is when I operate overseas, it's very hard to do medial femoral condyle. Like you go because you need to do 5-10 cases per day, and the setup is not perfect. You need something slightly easier, number one. Number two, you know very well, in rib harvesting, I do it a lot of different cases. If someone is a fluffy 4 or 5, I call it, we have fluffy classification because of the size. Sometimes you have to take big devers to get to the rib and resect it and stuff. It's not that simple. So anyway, this is where it came from. So
yeah, I think it's a great answer. And what I really look forward to is more than the biomechanics studies, because I believe that the mid-carpal resection is not going to cause kinematic differences. It may cause scar tissue in the mid-carpal joint, but it's going to cause kinematic differences. And I do believe that regardless of destruction of the scapholunate ligament, if we restore the height of the scaphoid, you'll maintain normal radiolunate angle. I believe that, and we've shown that. What I really love to know is the sort of longer, intermediate to long-term outcome functionally of these patients, and how's the cartilage going to hold up over time.
So Bassem, this is so innovative, and it's really something we expect of you. You're such an innovator in the field. So congratulations on this.
Thank you.
I guess I'd like to know, like, how many patients have you done? I know you mentioned your longest follow-up was 8 to 9 years, and most of those patients like proximal pole non-unions without humpback deformity, or is that essentially the patient population you're looking at?
So the majority of patients are either a patient who has, well, for me, like everyone has their definition, but if you have a fragmentation of the proximal piece and the small and non-union, for me, this is not reconstructible. And the patient, the majority, believe it or not, are done overseas. It's very interesting because when we came up with the technique, there's a center in France, they did 6 in a row, and now it's their way to go because it is relatively simple. And Rob can comment today. He did one today. He can comment about it. I'm not sure if it's your first one, Rob.
Yes, right. For us, this data is a little.
It's like, okay, I thought Rob is talking, but he's not talking. I said, who's talking? You can comment about it, Rob. But Harvey, the majority of cases were overseas. And in fact, Scott Wolf was trying to do a study, Mayo, at that time, Mayo HSS. And I told him, but I have much more numbers overseas. And this will become tricky because to get an IRB from France and from Jordan, Lebanon to collect these cases become much harder. But we're gonna get this data, we're gonna get it out because, to be honest with you, and don't take me wrong, if it was my own wrist, I want a hamate. If it's me, I prefer not to have medial femoral condyle taking from my leg to put it in my scaphoid. But this is only me. So if I can find something, and I don't want the rib, so I will have them. This is me. But again, so far, the one that I've done, they have been very, very encouraging. But yes, as Jim said, absolutely, we have to get a longer follow-up on a number of cases, document what happened over time. I can tell you from and Jim can of course comment, he's much better than me in this, but when you get this piece fresh, I remember I had an argument with Alan Bishop because he said, oh, this is a dead bone. I told him, this is not a dead bone. This is a completely living bone, but it's not vascularized. It's almost like an acute fracture and you're fixing it because everything is in it. So we have to get the long-term follow-up, and I would love to hear from Rob quickly. How did he think today when he did his first time? How did it go?
Yeah, so I'll present the X-rays for that. This is my 4th one I've done actually, and so it's
sorry.
fun.
Okay, good.
No, it's fun. One of our fellows brought up this technique after one of your guys' papers, and we tried it out, and I'm not going back to anything else. So I'll show you the X-rays of the case we did today, but I think it's to Jim's point though, the long-term follow-up, whether the cartilage will hold up, those types of things have to be answered. But certainly, if you can get it to heal, for my practice, this makes sense in small proximal pole non-unions.
Rob, you'd mentioned it even in the chat there about the type 1, type 2 lunate issue, and I saw the you know, that paper from Syracuse from 2004 where they were doing proximal hamate resections. They had noted that all those patients were type 2 lunates, and they were halt lesions, so it's a different population. But in the study, Bassem, that you had done, that I think was published in, I think I said, it was 2020. Those were all type 1s, I think, if that rings a bell. Yeah.
Well, it is sometimes not easy to get wrist cadaveric and try to take X-ray to see if it's type 1, type 2. So whatever we can get. But honestly, I think it will be very, very interesting to try truly to find cadavers, wrist that are type 2, collect them and try to do the study on them, because I know it's going to be different somehow. But again, cadaveric study, you get 8 hands or get 8 wrists. You're lucky if you get type 1 or type 2. Well, the majority is going to be type 1. This is why, but we'd not look specifically at the type 1, type 2. But I told Sanj, we really have to try to see anytime we get X-ray in type 2 on the cadaver, we start to collect them only as a type 2 and try to do study on them as well, because I know the kinematics will be somehow different.
What would be your speculation, Bassem? Looks like we have 1 minute. I've always thought maybe if it's type 2 and there's a hamate facet and you remove the proximal hamate, then maybe that would put you more at risk for lunate extension, or what is your?
I honestly don't think so. The only thing with the type 2 is the shape of the hamate. Like whether the shape of the hamate, when you try to key it in, is gonna change. But I do not think necessary is gonna affect specifically majorly the changes, like the shape of the hamate, because when it changes, it affects how you put it on the scaphoid, and the whole proximal row, like it may be slightly changed. That's the thing what I think is going to change.
Awesome. Do you have a limit to how much of the hamate you'll take? So I was wondering this as I was doing the case, and I'll show you my X-ray from today, but you can go up pretty high, then you start getting to the hook, then you start wondering about what's on the volar side.
Well, that's an excellent question. Again, up to 60% based on our basic study, it did not affect much the kinematics. 60%, which is like, this is most what you need if you need proximal pole, because I know if you want to take more than that, it's not proximal pole anymore, you know. But proximal pole, even the third, like you can get up to 60% of the hamate, and it should not affect much the kinematic.
Okay, great. Well, you know, we want to leave some time for our second paper as well. So next we have Dr. Rob Kamal, who will be talking about his paper, and Carl Eberlin will be moderating this part of the discussion. Rob, please.
Great. Thanks, Harvey. So the paper is entitled Clinical and Patient-Reported Outcomes After Hybrid Russe Procedure for Scaphoid Nonunion. So this will be a great discussion. Again, please, everyone, feel free to enter comments in the chat, and appreciate everyone keeping their microphones muted. So Rob, why don't you get started?
Great, thank you. So thanks for having me. I did want to start with this case just to continue this discussion, and we can talk about it later, but this was fortuitously one of my cases from today. So this, I think, low 30s female that had not had treatment and had just continued wrist pain. And I don't know if she meets Jim's criteria for size, but I saw this size and I was concerned in terms of getting a screw in this once I took it down. So we did this case, and then here are our x-rays. So on the left is after excising and then sort of cleaning out some of the sclerotic bone. And some of what I'll talk about in terms of our paper is just how important it is to get all of the sclerotic bone out, regardless of the technique. But certainly if you're using, you know, just cancellous or cortical-cancellous graft. And then in the middle left there is after the hamate. And this is where I asked Bassem sort of how much can I take? Because I measure 8 millimeters and then I want to cut at 1 centimeter. And then I want to maybe, you know, give myself another millimeter for the kerf of the osteotome. And I don't want to use a sagittal saw all the way down because, you know, the recurrent motor branch, etc. And then you can see on the right there, my x-rays with the reconstruction, which I think lined up pretty well. To Jim's point, the patient never really had a lot of DZ, even preoperatively, but had a lot of wrist pain. But we also, our approach, we took between DRC and DIC for the proximal pole. We took some of DRC down, but really didn't do the traditional Mayo capsulotomy. And then we split some of the fibers of the DIC to get to the proximal pole, the Hamate. And so we were able to really do this without disrupting a lot of the secondary stabilizers, to Jim's point. But to the paper that we're going to discuss that we had published, and I should thank my co-authors, Lauren Shapiro's staff at UCSF and Ali Rose, fellow at Duke, and they both helped with this. But just some background with scaphoid nonunions and specifically the Russe technique. And so you can see the dates there from 1930, so almost 100 years now. But that description was a dorsal approach to the scaphoid and cancellous grafting of the non-union site. And then Russe in 1960 used a Palmer approach and described cortical cancellous graft and really sort of highlighted some of the advantages of the cortical aspect of the bone in terms of rigid fixation, humpback deformity, etc. And then there have been a number of sort of modifications to that technique. Here's one from Stark that showed 81% union, 40-month follow-up. They used iliac crest. And then again, another modification using bone from the distal radius, 91% union rate. So pretty good results for scaphoid nonunions. And Steve Lee and Scott Wolf really then described and pioneered this technique of the hybrid approach, which is similarly using cortical bone graft and cancellous bone graft, but adding a headless compression screw to add some sort of rigidity to the construct. And so they described their technique, 17 patients, 100% union at 32 months. And really the question that we had, in our group was, is this reproducible or not? And so to some of the points that Bassem made earlier, you're coming out of practice and you don't maybe don't know the sort of the learning curve for a new technique. And so to some degree, for my own testing, I wanted to see sort of how was I doing in learning this technique. Similar to Bassem's technique, my experience in learning this was just a fellow having come across this paper and suggesting we try it out. And before that, I had done different sort of pedicled grafts for reconstructing scaphoid nonunions. So, our question really was, is the union rate really going to be 100%? Is the technique reproducible outside of the describers of the technique? And how are we doing? So this is a retrospective review, scaphoid nonunions with humpback deformity, treated for a couple of years. They had to have at least a 3-month follow-up, which is traditionally where I'll get my CT scan. And then a number of sort of X-ray findings in terms of the posture of the carpus, sort of pre and post-operatively. And then the patient-reported outcomes in terms of pain and function. So here are our results. So we had 95% union rate based on CT scan at around 3 months follow-up. One patient had persistent non-union. 90% had symmetric range of motion compared to the other side. And then we had, beyond the non-union, we had one complication with pain from the hardware that resolved after hardware removal. And on the right-hand side, you can see sort of pre and post patient-reported outcomes, as well as some of the radiographic findings in terms of reduction in pain, improvement in function, and then improved alignment of the carpus after the reconstruction. So hybrid Russe procedure we thought was reliable and reproducible for humpback deformities for scaphoids. It restored sort of radiographic angles. And really the concern from the prior case series was that there were no non-unions. And we did have one non-union, as you might expect with any scaphoid non-union surgery. So thanks. Look forward to discussing.
Thank you very much, Rob. Next, we're going to have Chao Long, who is a resident at Hopkins, discuss this paper before we have Dr. Higgins give his comments. So Chao.
Great. Thank you, Dr. Kamal, so much for that presentation, but also for doing the study, because I really do think that the reproducibility of any procedure is particularly important for the trainee to think about. You know, in this context, just because you or others can achieve a 95 to 100% union rate, does that mean I'm going to be able to deliver those results, you know, in my first year of practice? So having this study to support the reproducibility of such high union rates, I think is really helpful. For me, I think the crux of the paper really is when you choose the hybrid Russe versus move to a vascularized bone graft option, because if you can achieve a 95 or up to 100% union rate, it brings into question when vascularized bone grafting is really necessary. When I was thinking about this, I thought that it should be informed by not only this paper, but also the larger body of evidence that we have surrounding this question. We don't have time to review that, but you know, there are meta-analyses out there. One of the ones I reviewed was greater than 5,000 scaphoid non-unions, and they do report in those meta-analyses higher rates of union with vascularized grafts as compared to non-vascularized. So, you know, sitting here thinking about your study as well as the larger context and the larger evidence, it's challenging to interpret when the literature isn't convergent. But for me, you know, I was asked to comment on how my future practice would be influenced by the study. And I think that my algorithm would hinge on 4 questions. First is, what risk factors does the patient have for non-union? So, you know, you mentioned that there was one patient in your series with a non-union, and I'm curious how this informs or influences, if at all, your patient selection for this procedure going forward. And, you know, the standard risk factors, including duration and the worrisome fracture traits, et cetera. The second question I would ask is this a revision non-union surgery? So has there been previous instrumentation? If yes, of course, I would favor a vascularized bone graft option. And third, is there evidence of avascular necrosis? You know, even though I think previously this was a standard indication for choosing a vascularized bone graft, I actually learned from Dr. Higgins the challenges of diagnosing avascular necrosis accurately, and also, you know, in light of comparable outcomes in avascular necrosis with both vascularized and non-vascularized techniques. You know, I think that there's some question of whether AVN should still be used, but I do still think that as a new attending, I would favor getting an MRI to have another data point for preoperative planning. And finally, I think it would also be important to think about my familiarity with this technique. I think the reality is that if I've been trained to do this procedure and therefore have a lot of comfort and therefore a lot of confidence in it, I may think that in my own hands, I could achieve a 95 or 100% union rate, but otherwise, perhaps I would favor leaning on the data from the meta-analyses in the broader literature and opt for a vascularized option before using the hybrid Russe. So those are just a few thoughts.
Great. Thank you, Chao. I think it's very clear with these procedures, there is a real important balance of the technical carpentry as well as the biology, which I think is about much of our discussion will lie on that. So Dr. Higgins, let's allow you to share your comments and then we'll have some discussion.
Yes. So I'm sharing screen now. Hopefully that's working. So great review by Chao and also by Nick. I applaud them both. They're both superstars at Hopkins, and we've had such great experience working with them. My comments on this paper, and I thought this is a super useful paper, and it would appear, hold on one second here, I'm no longer in control of my screen. Let me share again. It's not letting me share the one I want to share. Okay. So you can see the screen now, right? With the
yes, we can.
Russe. So this is, you know, I think this technique is super underrated in that it's technically, the carpentry is the hardest part of these operations, regardless of where the blood vessel is or is not, or if it's a microsurgical case or a pedicle. But I think the carpentry is the hardest part, and for sure, we look back on the masters like Diego Fernandez and people that initially had fewer tools in their toolbox other than just pure skill in carpentry, and that's something that is an art that should never be lost. And this is speaks to Rob's capability as being able to reproduce this difficult operation. But I often will get a question from our fellows asking, hey, how do I make decisions about vascularized versus non-vascularized, just as Chao had said. And if you think about, how did we get to where we are? In the early days, we had some poor success rates with conventional bone grafting that were published in the 70s, 80s. And then we all concluded that it was because of this issue of retrograde blood supply to the scaphoid, and we all know that where your scaphoid is fractured tended to impart different risk factors. And then this huge landmark article came out by David Green saying that, I was actually looking at punctate bleeding or not, and I rated the scaphoids accordingly. And this is maybe one of the most referenced articles in all of hand surgery, certainly in the world of scaphoid nonunion surgery. But this seemed to be the key issue, was the proximal pole vascularity and trying to determine AVN. We certainly know that vascularized bone grafting is a powerful tool, and it does work, and that's unquestionable. And I think regardless of great reports with vascularized or non-vascularized grafting, we know, and it's been shown by great studies like this one by Alan Bishop, that, and this is in an animal model, I won't go into it, but if you're ever interested in reading the story, this paper really shows the power of vascularized bone grafting. So we know it's a good tool, not just in long bones, but also in carpal bones. But the issue is we don't really know when people truly have AVN. And you would think punctate bleeding should be the gold standard, or maybe histology should be the gold standard. But even though it became embedded in our literature that AVN was the primary reason why you'd use vascularized bone, it became clear that there is no gold standard. So with or without gadolinium, MRI, CT scan, plain X-ray, histology, punctate bleeding, none of those were reliable. So I think as a result, we were left in this situation where we have equally good results seemingly published for vascularized and non-vascularized bone grafting. We've got meta-analyses showing limited quality because the stuff going in was just the same as the quality of the stuff coming out. There's a lack of consensus about what is and what is not AVN. And then a free flap came along. So now you've got like increased complexity. And people were saying, if this is going to be the standard vascularized bone grafting, maybe we should just go back to the well and use the standard non-vascularized bone grafting. So our only 2 randomized controlled trials, and if you haven't read these, I would urge you to do, because it's amazing to even know that these exist, that we have 2 randomized controlled trials. But these show slightly different results here. One showing that vascularized bone grafting was superior in the Reback study. However, they didn't have adequate power to test all of the preoperative risk factors, and I'll go into that in a minute. This Braga Silva article showed that there was no statistical difference in union rates. Again, power was limited, believe it or not. And why is that? And I think it's because there are so many different things that people study. All these preoperative factors, right? Like, how did the patient come to my office? And then all these treatment factors. Did I go long arm or short arm? How long did I cast? Was there a blood vessel attached or not? Did I use a screw or did I use K-wires? So I think if we could just separate these things out and uniformly report them, and this, I'm not going to be the first one that makes a plea for uniform reporting, but just focus on preoperative factors. These are the ones that everyone always talks about. And if you remove AVN because it's difficult to prove when or when it does not exist, I always say to our fellows, guys and gals, look at these 6 preoperative factors, and you should decide your algorithm based on these risk factors, because they are super important determining when you're going to fail. Now, these are risk factors for failure of non-union surgery, not failure of scaphoid surgery, failure of scaphoid non-union surgery. So I think, like in Rob's case, this is fantastic carpentry, but if you look back on, these have all been shown in various studies to be of tremendous importance in terms of your prediction of failure. So these patients, the duration of non-union was not stated in these papers, so we don't really know how long it is. And the cutoff here that seems to be important is it before or is it after 6 months? Some have been before or after a year as what is the critical time where the scales tip against you. Location of fracture, they're all wastes. We know that the proximal pole, and the smaller the proximal pole is, the more likely you are to fail. Is it a fragmented proximal pole? and it's their combination. So in this case, it was favorable. And by the way, Rob, I'm not saying you just get all easy cases. I'm just saying that if we were to classify this article, we would see that there was no previous instrumentation. They all, however, did have humpback. So in this category, they were a higher risk. So if it's binary, if each of these are high risk or low risk, you were high risk in the humpback category, and smoking was unstated. So let's assume that in the unstated categories, meaning the duration of non-union and the smoking, that those were shorter duration and all non-smokers. You know, the correct way to, I think, phrase a very valuable study like this is to say, in this series of 21 scaphoid non-unions with one of the 6 identified risk factors for failure, we demonstrated a 95% union rate. Because I think when you look at meta-analyses, or if you're a fellow and you're saying, how am I going to, how's my practice going to go? And you notice that this attending likes vascularized bone, or this attending likes non-vascularized bone, or this attending likes volar radius or dorsal radius. You have to figure out, when am I going to use those arrows and pull them out of my quiver? Is there any rhyme or reason to it? Or is it just because I get, you know, I've got a hammer and everything looks like a nail? So I think it's important to really try to determine what is your risk going into the surgery. These factors, by the way, are all not equal in risk. If we had a way of creating a score, a risk score, right? We have risk scores for a lot of things in medicine. But if we had a risk score, it would be 1 through 6, but not all these should probably be weighted equally. And in fact, if you look at the literature, the one that I think is the most fearsome, and for me is certainly the most fearsome, is previous instrumentation. So previous instrumentation, way worse than the patient smoking. And it doesn't matter, cigarettes, cigars, Marlboros, they're professional grade smoker, maybe they chew a little tobacco. But if you've had multiple surgeries before, that's a big problem. It's such a big problem that if you look at these studies, which are fantastic studies, they show a dramatic difference in the first time non-union. Now, these are not, I'm not talking about primary scaphoid surgery. I'm talking about scaphoid non-union primary surgery versus revision. Huge difference. The case series that are dedicated only to scaphoid non-union revision cases have very low success rates. And in fact, the 2 meta-analyses that I mentioned actually excluded revision surgery as part of the exclusion criteria because it altered the scale so dramatically. And for me, the largest series of a really well-performed study, and I would recommend everyone read this, is this Poulos 2018 study on MFC for revision surgery in 49 patients with an 84% success rate. In revision surgery, that's a high number. So this, for me, has something that's been really influential in my development of my algorithm. I would just urge the fellows and the trainees in the crowd, you've got to say to yourself, don't just choose something because you feel like you're pretty good at it. You've got to say, not all scaphoid non-unions are built the same, and I'm going to pull out different arrows out of my quiver for whatever the problem may be. I'm done talking, Kyle.
Great. No, those are awesome comments, and there are a few questions in the chat. You know, one of the questions, Rob, was about how you first started doing this technique and whether you did it on a cadaver first or during fellowship. And I'd like to extend that question and ask if you could provide some of the technical pearls that that you use to achieve this type of success rate, because I find it to be pretty finicky to get that graft to fit in and to get the screw in and not spit out that the cortical part of the graft, which we've all seen. So, I mean, give us some pearls here.
Yeah, great. Well, I want to thank Jim for that review and review of the literature. I think it's incredibly helpful. I have some thoughts just on those 6 principles that Jim brought up that we could sort of review. But if you're considering treating a scaphoid non-union, whether you're using a vascularized graft or not, one of the principles I think that is incredibly important is removing all the sclerotic bone. And in some cases, that means getting all the way down to a shell of cartilage and getting all of the bone out of the proximal pole, which I do sometimes for these wastes. So, I would agree with Jim that there's not a lot of consensus on what is AVN of the proximal pole or not. Certainly in the literature, it's a little bit all over the place. And so punctate bleeding, no punctate, I don't drop the tourniquet. I don't look If it looks a little sclerotic on X-rays or the pre-op CT scan, doesn't change my algorithm in treating these sort of waist non-unions with humpbacks. But if you do see sclerosis in the proximal pole, you know that you have to get your burr all the way down till you have sort of an eggshell of cartilage left and get sort of all that bone out, and then stuff it with really, really good cancellous bone graft. So that's the one thing, at least here, what we go through with the fellows is getting the bone out that looks a little white and hard till you get nice yellow, sort of fluffy, soft cancellous bone to the scaphoid.
See, we're getting back to the fluffy. Bassem, I think I enjoyed that comment. No, but actually, I wanted to ask all of you, how do you decide when to stop debriding? I mean, I think the more junior surgeons are going to be a little bit more timid, perhaps, about really getting in there and debriding. So where's the finish line there? Maybe you guys could comment further about it. Jim, what do you think?
I agree with Rob. I don't drop the tourniquet. And, in that green study, it's interesting if you read carefully, pick through it, he began by dropping the tourniquet. By the end of the study, he was not actually dropping the tourniquet and declaring punctate bleeding or not with the tourniquet up, which probably is actually legitimate. But I don't drop the tourniquet. And I actually, at this point, and I'm curious everyone else's take too, when a scaphoid nonunion comes in, an MRI is no longer part of the workup for me, nor am I looking with close attention on the CT scan to see if I have some sensitive. It looks denser and is AVN part of the makeup of this patient's problem. I think there are plenty of ways we can get fooled. I do think it's important to debride the fracture line aggressively, for sure. And I think in the end of the day, that's part and parcel of good carpentry. And Rob obviously showed us what good carpentry is. So I think you can be as fancy as you want with blood vessels from different limbs or from the same limb. And if you end up with wires that are ill positioned, or you could have had a screw and you lost the opportunity at internal fixation because your guide wires were ill positioned, you ended up with K wires and semi-solid fixation. To me, that's the crux of whether or not I'm leaving the operating room feeling, this case really went well, because it's hard to make up for that no matter how good your anastomosis is. So the carpentry is the most important part. I would agree. I definitely think it's important to shell it out. And I think one of the hardest things I would say as a fellow, and this is like the nirvana moment, is if you're trying to open up a humpback and you're opening up volarly and you want to get that wedge in volarly, and no matter if it's free, if it's pedicled, if it's non-vascularized, getting that piece in there with cortical cancellous strut such that the cortical cancellous strut is dorsal to the volar rim of the distal pole and dorsal to the volar rim of the proximal pole, as if it's a clam, and you now got this thing sort of trapping it. Whereas if you sometimes put the bone graft in and it awkwardly fits and you're worried it's going to escape, we use this word escape as if it's running from jail, it may escape in your post-operative x-ray. That's really disconcerting. So the best moment of the case, no matter what the anastomosis is later, is if you get really good carpentry and that piece is inside there and it's really propping it open. That's hard to do. It's hard to do. And I think when it happens, that's the moment of great scaphoid surgery.
Agree. Rob, any other thoughts about that?
Yeah, no, I agree with Jim. Certainly the carpentry and then getting your graft in so that you sort of almost, certainly with this hybrid technique, don't necessarily need the screw, or at least it almost becomes this rigid construct when it collapses down onto the graft. Some of the tricks I've used, depending on how much I'm shelling out, sometimes it's really hard to open that up enough to get that entire sort of football shaped graft in there. And so I've sometimes made these little slots on the volar surface, like a couple millimeters up and down on each side, so I can slide that graft in without shortening it so much to get it in to where when I collapse down the scaphoid humpbacks. So that's just one pearl I've done, but you're absolutely right. It's a little bit of a futz in terms of sizing out your graft to fit. Some of that depends again on how deep you're going in sort of your burring of bone and how much length you need on that graft, which you don't know till you prep it.
So I used to deflate the tourniquet early on. I don't do it anymore. But I want to tell like the fellows and those who haven't done the Russe before, what you see in the pictures is not what you see in the OR. In the picture, it feels like, okay, this is, and you put the bone, it's gonna nicely step, and it is not this way at all, by the way. It is very tricky sometimes. Sometimes you wanna correct the humpback and you have only like essentially one, like you have to stick the bone in on both sides and it's gonna go one way. And you try to correct it, but then you have to take it the way it is. All what I'm trying to say, it looks easy, it's not as easy. The concept is easy, but to correct exactly to look like the book, very nice 2 pieces with the bone in the middle, believe me, it's rarely this way, at least in my hand. And the tricky part about it is even the good bone, sometimes you shut it off to get this piece. Because sometimes you want to put this piece, you end up getting the sclerotic bone, and then you feel this piece is not going to fit in very nicely, except you get even more bone. So you get even the good bone slightly out. And sometimes you have to do 2 pieces. Many times I've done 2. But I really feel still, everyone said the carpentry is not as easy as it looks in books. So that's my advice.
Great. Well, we're going to wrap up in a moment, but I want to ask a final question of the panelists and our expert. I know you like that term, Jim. What is the role of pedicled bone flaps, such as the 1-2 ICSRA flap in 2022? We see great results from the modified Russe approach. Obviously, the MFC, MFT results are awesome, but what's the role of pedicled bone flaps?
Jim?
I think every fellow is going to have to develop a taste for how facile they are with each of these and come up with an algorithm based on risk factors. But for me, and this is an opinion, this is where the opinion starts, the pedicled grafts, I think, are actually harder for 2 reasons. Number one, the vessels are remarkably small in some cases, so small that you lose faith in the middle of the case that you're actually delivering the product that you claim you're delivering. Particularly when you get your thumb on there and you start jamming it into the scaphoid and you say, boy, this vessel was so small in the beginning of the case, I could barely see it. Now I'm like manhandling this pedicled vessel. So with the MFC, MFT, you can position the bone exactly the way you want it. The pedicle is much larger and it gives you more of a sense, or it gives me more of a sense of faith that it remains perfused. The second part about the pedicle is that obviously your reach is limited. And so your ability to inset the way you'd like is more difficult. There's definitely a role for it. I think it's a good tool. I've used the 1-2 ICSRA many, many times. It's not something that I'm able to bring around to the volar side. I know people describe that, but for me, it's only via dorsal approach. So that means for me, if you're to use a local vascularized bone flap procedure, I'm much more often using the volar distal radius vascularized bone flap, because those are the higher risk patients that are collapsed and humpback and they need to open up. So that's where I'm bringing vascularized bone a little bit more frequently. So it's less common, but I think there's definitely a role for it.
Just Kyle, I want to add, yeah, just quickly. I used early on in my practice, I did, I was at Mayo and we did a lot of these. I did a lot of these, but honestly, especially with the humpback, and the waist and nonunion, I do what Rob does. Like I've done the Russe, and I know they're slightly fuzzy, but the healing is great, and you don't need to do vascularized, because sometimes when you do them, you can definitely use them, but with this, most commonly I use them in this setting, and after that I don't. Right now, if proximal reconstruction, I do this the Hamate. Otherwise, I do the Russe, like Rob mentioned, but like without the screw.
Well, this has been such a great discussion, and I almost don't want the session to end. And I just want to ask one more quick question. I know we're running over. So Rob, you alluded that actually you wait 12 weeks to get your CT scan post-op. So I'm assuming you cast your patients for 12 weeks as well. So I just like to ask the panelists quickly, because I guess this is an important question. How long do you routinely cast your patients post-op, and when do you get your first post-op CT scan after a scaphoid nonunion?
Yeah, great.
I do 8 weeks.
Go ahead.
Yeah, go ahead. Sorry. I do 8 weeks, and then I do a CT scan at 8 weeks.
Yeah, my patients don't heal as quickly as Bassem, so I do a CT scan at 3 months, and I immobilize them till they're radiographically healed and clinically healed, and then the CT scan is confirmation for me.
I routinely will cast them for 12 weeks and then CT scan them at 12 weeks. That sounds super conservative. I think it is. I think I fear of failure because you want this to be the last chapter in the book rather than like one of a huge long novel. And so these patients have gone down a long road and they're usually willing to buy into that type of difficult postoperative period. I also think that, if you're freeing somebody up at 8 weeks, or if you're freeing them up at 12 weeks, I'd love somebody to prove this, but I just don't think that's going to result in a difference in flexion extension arc. Because 8 weeks of casting after pretty invasive radiocarpal surgery, I think you've already cast that die. So I go to 12, it may be overkill. And for me, it's sort of regardless of what the x-rays show.
So yeah, I used to get CTs at 6 weeks, but I no longer do it precisely for what you guys said. So it's really great points. But yeah, this has been really great. So I'd like to just wrap up by just showing a few